Hey guys, Jeremiah here to do a step-by-step breakdown of the trauma assessment. This video is going to be a little bit different from my other videos. It's going to be much more detailed. It's going to be very in-depth. It's going to be longer too. I might actually have to break this video up into manageable segments so that I can upload it. I apologize for any background noise you hear. I'm working on the ambulance today, so my radio needs to be on. Before we start, I want to cover a couple of things. First off, this is a 10-minute station. Secondly, the maximum amount of points you can receive for performing everything correctly is 42 points. The minimum you need to pass is 33 points, assuming you don't hit any critical fails. So I recommend that you strive for the maximum. We want you to get all 42 points. When you're testing, when you walk into the station, you should be read the following information. Welcome to the Patient Assessment Management Trauma Skill. In this skill, you will have 10 minutes to perform your assessment and voice treat all conditions and injuries discovered. You should conduct your assessment as you would in the field, including communicating with your simulated patient. You may remove the simulated patient's clothing down to his or her shorts or swimsuit if you feel it is necessary. As you progress through the skill, you should state everything you are assessing. Specific clinical information not obtainable by visual or physical inspection, for example blood pressure, will be given to you only when you ask following demonstration of how you would normally obtain that information in the field. You may assume you have two partners working with you who are trained to your level of care. They will correctly perform the verbal treatments you indicate necessary. I will acknowledge your treatments and may ask you for additional information if clarification is needed. Do you have any questions? Okay, what I just read is really important. First off, it says you need to voice treat all conditions. I highly encourage you, though, to go ahead and initiate any treatments like you normally would in the field. If the equipment is there, I suspect that they want you to use it, so go ahead and initiate the treatment. If the proctor doesn't want you to continue any further or use the equipment, then they'll stop you. Verbalize everything. That's really important. The proctor may, from time to time, have to look down and make notes on their sheet. You want to make sure that you verbalize everything so that they don't miss what you're doing. And then lastly, if you're looking for vital sign information like a blood pressure, they're not going to give you that information until you demonstrate how you would normally go about obtaining it. So if you're looking for a blood pressure, you actually need to take the blood pressure cuff, put it on the arm, put the stethoscope in the ears, put the bell on the skin, and pump up the cuff. Right? You need to perform the skill like you normally would if you were working out in the field. Okay? So that's what I wanted to cover with you before we started. For today, as I go through this scenario, the skill, we're going to use the following scenario. We're going to have a 20-year-old female patient who sustained a GSW, that's a gunshot wound, outside of a nightclub, and upon our arrival, we're going to find her lying supine on the sidewalk. 20-year-old female, GSW, shot outside a nightclub, lying supine on the ground. The trauma skill is broken up into 5 segments. Right? The first part of our sheet is the scene size up, or your scene survey. Secondly is our primary survey and resuscitation. Then you move down to history taking. Then we perform the secondary assessment. And then lastly, we perform our reassessment. So that's the 5 components of your trauma sheet. If you don't have your trauma sheet available, as you watch this video, I recommend that you find it and you look at it as I progress through the skill. When you walk into trauma, along with any other station, you need to say the following 2 things: BSI and scene safety. BSI stands for body substance isolation, and what that means is putting on the appropriate personal protective equipment when you're responding to the call. So at a minimum, it needs to be a set of gloves. Depending on your scenario, you might need a full gown, you might need a face mask or a face shield. So pay attention to this scenario. At a minimum though, make sure your gloves are on. So we start with BSI. Next is scene safety. I encourage you to say, I'm checking to make sure my scene is safe. If the proctor tells you you hear dogs barking or there's a dog running around the perimeter of a home, then you need to let them know how you would make it safe. So in that instance, you would say, I would call for animal control to contain the dog. If you heard loud voices or there was an altercation at the home, you would call for police assistance. If there was a fire, you would call for the fire department. So BSI, and I'm checking to make sure the scene is safe. Next comes our mechanism of injury. So your mechanism is forces or factors applied to a body that cause injury. So in this situation, the factors or forces applied to the body was our GSW, right? Typically it's going to be what you're dispatched for. So your mechanism of injury in this scenario is a GSW. When you're testing, it could be an ejection from a motor vehicle. It could be a stabbing. It could be a fall. So pay attention to what you're dispatched to. So we covered BSI, scene safety, and mechanism of injury. Next, we need to determine our number of patients. So you would say, it appears I have one patient. That's important because we want to make sure that we have enough rescuers for the number of patients. Next, we need to call for EMS assistance. I teach my students to say EMS assistance or ALS. ALS stands for Advanced Life Support. Typically, that's a paramedic. Following that, we need to have our partners hold C-spine. C-spine is short for cervical spinal immobilization. Because this is a trauma, we're concerned about the potential for head or neck or back injury. Specifically, we're concerned with head and neck, so we're going to have our partner hold C-spine in a neutral and aligned position and don't let go. And that's done by simply having a partner come over, take their hands, and grasping the side of the head and holding the head so that it's in a neutral and aligned position. We want to make sure that the patient or nobody else grossly moves the head out of alignment. So you would say, I'm going to have my partner hold C-spine in a neutral and aligned position and don't let go. Right, so we just covered the first part of our scene size up. There were 6 components. It's BSI, scene safety, mechanism of injury, number of patients, calling for EMS or ALS assistance, and having our partner hold C-spine. Next, we move on to the primary survey resuscitation. Remember, per your textbook, the purpose of the primary survey is to identify and treat immediate life threats. When I say immediate life threats, I'm talking about things that would threaten a person's airway, breathing, or circulation. So some examples would be a foreign body airway obstruction if a patient was choking. Another example would be an arterial bleed. Another example would be a sucking chest wound in the possibility of a pneumothorax. Right? Those are all things we need to treat right away. So as you progress through this part of the sheet, when we get to primary survey, the first thing we're going to do is form a general impression. Typically the general impression is done from the doorway, and your general impression doesn't involve any physical contact with the patient. It's observable. So what you would say is, I appear to have a 20-year-old female patient who's lying supine outside. Based on the mechanism, I can assume that the patient's injury is severe. Okay, so again, it's what we observe, and in medical situations, we say that the general impression is going to help to determine if our patient is sick or not sick, and in trauma, it's going to help to determine the severity of the injury. So I teach my students, it's a severe injury or not severe, right? And that's going to help to guide our transport decision. It's also going to help to set the pace for this call. So again, I would say I appear to have a 20-year-old female patient lying supine outside with severe injury. Next, we need to assess responsiveness. Because this patient is unconscious, we use the AVPU scale. That's A-V-P-U, AVPU. So I recommend when you walk in, you want to ask if your patient is alert. If the patient is not alert, then we move on to verbal stimulus. So you would direct a question to the patient. You would say, "Ma'am, can you hear me?" If there's no response, then we need to assess for painful stimuli. We assess painful stimuli by grabbing the trapezius muscle that's up in the shoulders. So what you would say is, I'm going to assess for painful stimuli by grabbing the trap muscle. The proctor is going to advise you as to whether or not there's a response. If there's no response, then you would follow it up with, "My patient is unresponsive." So alert, verbal, painful, unresponsive. Ask if the patient's alert. Say, ma'am, can you hear me? Painful, grab the trapezius muscle. We also say we're grabbing the trap. And then you would verbalize this patient is unresponsive. Next, we need to determine what the chief complaint is. Typically, your chief complaint is reported to you by the patient. It's how they're feeling, or it's the reason that they called for EMS, but it's going to be reported to you by them. Because this patient is unresponsive, we don't know what the chief complaint is. So when you get here, you need to say, my chief complaint is unknown because my patient is unresponsive. Next, you need to determine if there's any apparent life threats. And in order to adequately do this, you need to expose your patient. So I recommend that you verbalize doing it, and if it's possible, you actually expose the patient. So again, my chief complaint is unknown because my patient is unresponsive, and I'm now going to assess for any apparent life threats. So I would expose my patient, and we're looking for any threats to airway, breathing, or circulation. All right, we would make sure that we cut the pants off, and we're going to look from head to toe. So for example, if you had an arterial bleed, you would need to go ahead and try to stop the bleeding. So that's done with pressure, more pressure, and then a tourniquet. I have an example of a tourniquet here. If you're applying a tourniquet, make sure that you apply the tourniquet proximal, okay, above the injury site. You want to make sure that when you apply the tourniquet, it's tight. And once it's applied, you want to make sure that the bleeding has actually stopped. Okay, if I were to apply a tourniquet, this is a CAT tourniquet, I would place it up on the arm. We're assuming that the patient had an amputation somewhere below the elbow. Put it up high on the arm. We would make sure that we applied it tightly. We would twist our windlass until the bleeding stopped. On a side note, you would want to make sure that you wrote T on the patient's head. We want to note the time that the tourniquet was applied. We're going to make sure that the bleeding has stopped. And then you want to make sure that you ask your proctor whether or not your intervention is adequate. So that's an example of what you would do for an arterial bleed if you found it as an apparent life threat. Okay, in this situation, our patient sustained a GSW. Okay, GSW is a gunshot wound, so we can assume that there's a penetrating hole to the patient's chest. When that happens, okay, it can result in a sucking chest wound. And a lot of times, we're also worried about the potential for a pneumothorax or a tension pneumothorax due to the injury sustained here. So a sucking wound is a hole in the chest from a gunshot wound, a stabbing, any sort of puncture to the chest that's going to allow air to travel into the chest cavity. Right? Sucking chest wounds are dangerous because they can cause pneumothoraxes or tension pneumothoraxes. Treating a sucking chest wound requires two things. One, we need to keep air from getting sucked into the chest, and we also need to allow any trapped air to escape. Right? It's called a sucking chest wound because if you listen when the patient inhales, you might actually hear a sucking sound. Right? When the patient exhales, you might actually hear a hissing. Another thing you may see is frothy blood. You might see blood bubbling from the hole or the wound. So if you hear those things, the proctor indicates that you hear sucking coming from a wound, or the proctor indicates that you have bubbling blood coming from a penetrating wound in the chest. You need to suspect that it's a sucking chest wound. The way we treat a sucking chest wound is with an occlusive dressing. Okay, an occlusive dressing is typically something you may need to make. Right? You can't just go on Amazon, you can't go to Boundtree, you can't go to any of the medical supply stores and buy an occlusive dressing because it doesn't really exist. We make them out of other materials. Okay. Typically in the past, petroleum gauze strips have been used to manage sucking chest wounds, and all it is a 4x4 piece of gauze. It's a 4x4 bandage that's been soaked in petroleum or Vaseline. If you don't have petroleum gauze, you can use any sort of plastic from any sort of the sterile bandages, from any of the items that you find in the ambulance. Right, an example would be the plastic that I have here from this chest seal. What I could do is peel the plastic off, and then I'm going to tape it over the sucking chest wound, over the puncture, and then I need to tape it down on 3 sides. Taping it down on 3 sides allows air to escape from the one side that isn't trapped. Some organizations carry a chest seal. This is an example of a chest seal. It works like an occlusive dressing. What I would do is peel the backing off, and I would place this over the puncture hole, the penetration, and this is going to work in a similar fashion to allow venting of air, to allow air not to get sucked in, but allowing air to escape. Right? The military uses chest seals. We don't see them a lot pre-hospitally, but if you do, wanted you to be familiar with it and know how to use it. Okay, so if you find puncture penetrating hole to the chest, you want to treat it with an occlusive dressing. What you would do is apply it over the hole, tape it down on 3 sides. Once you do that, you want to ask your proctor if your intervention is adequate. Okay, so I've just treated my apparent life threats. Next, we need to move down to airway, breathing, and circulation. So we're going to start with the airway. I want to open the airway with a jaw thrust maneuver. Again, we're worried about trauma, we're worried about potential head and neck injuries. So I don't want to open the airway with a head tilt chin lift maneuver. Manipulating the head and the neck could make any potential injuries worse. So we're going to use the jaw thrust maneuvers. You can have your partner or your second rescuer open the airway using a jaw thrust maneuver. Next, what you want to do is assess the airway for any obstructions. Right? We're looking for blood, vomit, secretions, mucus. Okay, maybe there's teeth in there. You want to make sure that there's no obstructions. If the proctor indicates that there are obstructions, you need to go about removing them. So how do we remove obstructions? Typically that's done with suctioning. So what you would say is, I'm going to suction the patient's mouth. I'm going to measure the corner of the mouth to the tip of the ear. I'm going to insert no further than I can see. Now I'm going to suction in circular motion on the way out for no more than 15 seconds. Then I would ask if your airway is clear. Next, you need to measure and insert an airway adjunct. Typically we use an OPA, an oropharyngeal airway. Here's an example of an OPA. Remember, we insert from the corner of the mouth. Remember, we measure from the corner of the mouth to the tip of the ear. And then you would insert tip towards the roof of the mouth, rotating 180 degrees, and the flange should rest on the patient's lips. If your patient starts gagging, that's not good, so we need to make sure that we remove the OPA. We would have to manage the airway without it. So insert your OPA, ask if your patient accepts. Remember, these mannequins have limitations. This mannequin does not accept OPAs. It doesn't mean that I shouldn't verbalize performing the skill, because that could mean not getting the point that I need to pass. It could also mean a critical failure. So make sure if the mannequin doesn't accept an OPA, you verbalize it. Right, so I just assessed the airway. Now I need to assess breathing. We assess breathing by looking at the chest, and we're going to look for the rate, the rhythm, and the quality. So if you're here, what you need to say is, I'm going to assess my patient's breathing. I'm looking at the chest. I'm looking at the rate, the rhythm, and the quality. Right? What we're looking for is a normal rate, should be between 12 and 20. Rhythm should be regular, and the quality, we should have good, equal rise and fall of the chest. In this situation, because my patient has a sucking chest wound and potentially a pneumothorax, I would expect to see unequal chest rise. Regardless, check the rate, the rhythm, and the quality. The proctor is then going to indicate what the rate, rhythm, and quality is to you. At this point, you need to determine what type of oxygen therapy you're going to use. Right? In most situations, you're going to have to choose between a non-rebreather mask. Here's your non-rebreather mask, or a bag valve mask device. Here's your bag valve mask device. If a patient is breathing between 8 and 28, we typically recommend that you use your non-rebreather. So if it's between 8 and 28 and you have good tidal volume, the patient doesn't have any labored respirations, isn't in distress, doesn't have diminished lung sounds, doesn't have shallow breathing, okay? If the patient doesn't have any of those and the breathing is between 8 and 28, please use a non-rebreather. If the patient is breathing less than 8 or greater than 28, or the patient has shallow or labored breathing, then you want to use a BVM. Okay? If a patient has labored breathing or shallow breathing, they're not getting good tidal volume. With labored breathing, they're working really hard to breathe. They're going to get tired at some point. So that's why we need to assist ventilations. That's why we use our bag valve mask device. We're going to help to manually and mechanically ventilate them. So 8 to 28 non-rebreather. If it's less than 8 or greater than 28, we're going to use a BVM. If it's shallow or labored, the rate doesn't matter. If it's shallow or labored, the rate doesn't matter. Use your BVM device. I hope that clarifies what oxygen therapy to use. Whether you use the BVM or the non-rebreather, it doesn't matter. We're always connecting it to the oxygen tank and we're setting it to 15 liters per minute. So what you would say here is I'm going to go ahead and ventilate my patient with a bag valve mask device connected to 15 liters per minute, 100% oxygen. And then you need to ask if your O2 therapy is adequate. If it isn't, you need to think about what you did that wasn't correct. Did you forget the OPA? Are you using the wrong oxygen therapy? Take a step back, reassess, fix it. Okay, so we covered airway, we covered breathing. Next we're going to move down to circulation. So when you get to circulation, you need to assess pulse, you need to assess the skin, and you need to look for any major bleeds. When we're assessing a pulse, when you're dealing with an unconscious patient, we want to check a central pulse. So we're going to check the carotid pulse. You find a carotid pulse by placing 2 fingers on the Adam's apple, sliding your fingers down approximately 2 centimeters and pressing it in. Right? You should be able to locate carotid pulse on either the left or the right side of the patient's neck. We assess for pulse by checking the rate, the rhythm, and the quality. Just like we did with breathing. You want to know the rate, the rhythm, and the quality. The rate we know should be between 60 and 100 to call it normal. The rhythm should be regular, and the quality should be strong. If it isn't any of those things, make sure you make a note of it. So we're going to assess the rate, the rhythm, and quality of the patient's pulse. All right, remember your sympathetic response. If you have a patient who's been injured, sympathetic nervous system is going to kick in. We could expect that patient's pulse rate is going to be a little bit elevated. So assess the pulse. Next, you need to assess the skin. So we want to check the skin color, the skin temperature, and the condition. You can do that by taking your hand, placing the back of your hand on the patient's forehead. You can really touch the face if you want, expose the patient, check their skin all over. So normally our skin should be warm, pink, and dry. If it's not that, make a note of it. We're concerned about shock. If your proctor tells you that your patient's skin color, temp, condition is pale, cool, and clammy, that indicates shock or hypoperfusion, and what we need to do is manage that. So if they tell you the patient's skin is pale, cool, and clammy, I want you to go ahead and verbalize that you're going to treat your patient for shock, you're going to apply a blanket. Last thing we want to do is look for any major bleeds. So again, we would expose our patient head to toe. We want to look for any major bleeds. If you find them, you want to treat them. Right? Again, because it's a major bleed, you're going to want to treat it right then and there. If it's minor, through capillary bleeding, from an abrasion, we're going to worry about that later. That's a secondary injury. Okay, so with primary survey and resuscitation, We covered our general impression, which is literally what you observe, covered responsiveness using AVPU. We verbalized that our chief complaint was unknown. We exposed our patient and looked for any apparent life threats. We assessed our airway, suction if it's necessary, and you insert an OPA. We assessed our breathing and we gave our patient oxygen. And then we assessed our patient's pulse, skin, and we looked for any major bleeds. Next thing you need to do is determine your patient's priority. I'm going to give you a little tip. When you're doing the trauma assessment, in many cases, your patient is going to be a high priority transport. So typically, you're always going to say your patient is a high priority transport. Again, because this is based on competency, right, you want to base it off of your GCS, which is your Glasgow Coma Scale. The GCS is going to help to determine the severity of a potential brain injury. GCS is based on eye response, verbal response, and motor response. Right now, my GCS is a 15. I have normal eye opening, my verbal responses are normal, and my motor responses are normal. So the maximum you can receive for a GCS score is a 15. The minimum score you can receive is a 3. You get 1 point for no eye movement, you get 1 point for no verbal response, and you get 1 point for no motor response. So this patient right here has a GCS of 3. So what I would say is, my patient is a high priority transport based on their mechanism and the fact that they have a GCS of 3. So we're going to transport right away. That's how I go about determining the transport priority in the GCS. If you forget your GCS, you clam up. At a minimum, you need to say, my patient is a high priority transport based on their overall condition and their mechanism of injury. But I highly encourage you to make sure you know your GCS. It's fair game for your proctors to ask you what the GCS is. Okay, so we just completed our primary survey. Next we move on to history taking. When you get here, you need to obtain baseline vitals. The 3 vitals they want you to obtain are a blood pressure, a pulse, and a respiratory rate. Again, you're not going to be given this information until you demonstrate how you would go about it in the field. Now, I know when we covered our ABCs, you obtained a pulse and a respiratory rate. When you get down here to baseline vitals, you need to do it again. Don't skip it because you did it a minute ago. Do it again. So when I get here, I would say I'm going to obtain baseline vitals. I'm going to start with my patient's pulse. I'm going to assess my carotid pulse for 5, no more than 10 seconds. What is my patient's pulse rate? At that point, the proctor should give it to you. Next, you want to assess the respiratory rate. So again, you would say, I'm going to expose my patient. I'm going to look at the chest. I'm looking for chest rise and fall. I'm going to assess the rate, rhythm, and quality of my patient's respiratory rate. At that point, the proctor should give it to you. Lastly, you need to obtain a blood pressure. Take your blood pressure cuff. Let the proctor know you're going to take the cuff. You're going to place it on the patient's arm. You want to then go ahead and put the stethoscope in your ears. And you're going to pump up your blood pressure cuff. And you're going to obtain your blood pressure like you normally would in the field. Once you demonstrate how you would normally go about it in the field, the proctor should give you your blood pressure. Okay, so we obtained our baseline vitals, we obtained a pulse, a respiratory rate, and a blood pressure. I don't care the order that you do it in. You can do your blood pressure first, you can do the pulse first, respiratory rate first, doesn't matter. Next, we're going to verbalize that we need to obtain a sample history. Because it's a trauma, it's adequate for you to say you're going to send your partner for a sample history. Say that, and that portion is done. Okay, so a quick recap. We start the skill with the following. My BSI is on, I'm checking to make sure my scene is safe. My mechanism of injury is a GSW. I appear to have 1 patient. We're going to call for EMS assistance or ALS. I'm going to have my partner hold C-spine in a neutral aligned position and don't let go. My general impression is a 20-year-old female lying supine outside with a severe injury. I'm going to assess for responsiveness using AVPU. Is my patient alert when I walk in? Verbal response, ma'am, can you hear me? Painful response with trap squeeze. This patient is unresponsive. My chief complaint is unknown because my patient is unresponsive. I'm going to expose my patient looking head to toe for any apparent life threats. If I find a life threat, I'm going to treat it. If I have a GSW, I'm going to treat it with an occlusive dressing taped on 3 sides. Is my intervention adequate? I move on to airway. I'm going to open my patient's airway using the jaw thrust maneuver. I'm going to assess the airway for any obstructions. If there's obstructions, I'm going to remove them. I'm going to suction. You suction by measuring from the corner of the mouth to the tip of the ear. You're going to insert no further than you can see. Suction in a circular motion on the way out for no more than 15 seconds. Is my airway clear now? I'm going to measure from the corner of the mouth to the tip of the ear and insert an OPA. I'm inserting tip towards the roof of the mouth, rotating 180 degrees. Does my patient accept? Next, I'm going to assess my patient's breathing and their respiratory rate. If they're breathing and it's shallow or labored, I'm going to use a BVM. If the patient's breathing between 8 and 24 and it's normal breathing, I'm going to use a non-rebreather. In this situation, my patient's breathing at 6 a minute and it's shallow. So we're going to go ahead and ventilate my patient using a bag valve mask connected to 15 liters per minute of 100% oxygen. Is my O2 therapy adequate? Next, we're going to assess circulation. We're going to assess the patient's carotid pulse because they're unconscious. I'm going to locate the carotid pulse. What do I find? Once the proctor gives you the pulse rate, you can move on. You want to assess the patient's skin color, temperature, and condition. If the patient is pale, cool, and clammy, we're going to treat them for shock by applying a blanket. Next, I'm going to check my patient again from head to toe, looking for any major bleeds. If I find them, we're going to treat them. Based on my patient's GCS of 3 and the mechanism of injury, I'm going to consider them a high priority patient. They're a high priority transport. We want to load them into the ambulance and transport right away. In theory, the rest of this stuff, the rest of the sheet's going to be done in the back of the ambulance. After that, we perform history taking. I'm going to obtain baseline vitals by demonstrating how I would normally go about it in the field. So I'm going to apply my blood pressure cuff, I'm going to put the stethoscope in my ears, pump it up and get my blood pressure. I'm going to assess the pulse again, and I'm going to assess my respiratory rate. I also want to make sure while I'm here, if I get my respiratory rate, that my O2 therapy is still adequate. Lastly, I'm going to send my partner for a sample history. Okay, so we just completed a good portion of the sheet. We're going to pause the video here, and we're going to pick up with our secondary assessment, the secondary survey.